Hello, thank you for attending our webinar today on HPV implementation science and strategies to engage patients, and we will be recording the webinar. We will be sharing the recording link and the presentations after the webinar. This webinar series was organized by the Illinois Cancer Partnership Prevention Subcommittee. The host and moderator for today's session is the co-chair of the Prevention Subcommittee, Eric Adjei. Now I will turn it over to Eric.
Thank you, Alice. Good afternoon, everyone, and thank you for joining us this afternoon. Today is the third part of our HPV Lunch and Learn series, and today we have three presenters. We're going to be talking about the role of oral health in HPV vaccination. We're going to touch on HPV vaccines hesitancy, which is very important in HPV vaccination. And then we are also going to talk about best practices and also interventions that could be implemented to increase HPV vaccination. So without wasting a lot of time, I'm going to introduce our first presenter. And I'm not going to read all their bios. Alice is going to paste their bios in the chat section so you can read about it. And if you have any question, please paste them in the chat section. Myself and Linda are going to be monitoring it. And we will do the question and answers at the end. So our first presenter today is Mona. Mona is the chair of Illinois department, the section chair or chief section chair, right, of Illinois Public Health, Department of Public Health.
Okay, do you want me to go ahead and share my slides?
Yes.
Okay, great. Okay, can you see my slides?
Yes.
Okay, perfect. All right, so thank you for this invitation to speak with the stakeholders of the Illinois Cancer Partnership. In the previous two sessions of this series, current data and important strategies in HPV vaccination were shared. And I hope that in my 15 minutes, I can add new and actionable information that can be translated to increasing the number of individuals who are vaccinated against human papillomaviruses. So in recent years, the incidence of HPV positive oropharyngeal squamous cell carcinoma has increased significantly. The red bordered arrows here highlight data that indicate for cancer of the oral cavity and pharynx, the incident rates in both sexes and death rates among males are increasing. In the lower blue arrows towards the bottom here, data indicate that the cancer death rates in the United States continue to decline overall, and for many cancer types, with the decline accelerated for lung cancer and melanoma, again, in both sexes. You know, at the oral health section at IDPH, cancer, early detection, and prevention are key objectives and indicators that are monitored at the state level. And this slide shows some of our documents, and details can be found in the Illinois Oral Health Plan 4, which is right here, as well as surveillance plans, which are both posted on the Illinois Department of Public Health's Oral Health section webpage. So a quick review of data that you've seen in the previous two webinars. So this slide shows that for HPV-associated oropharyngeal cancers, they're predominantly in males, but also in females, highlighting the importance of vaccinating both males and females. Looking deeper into the population in Illinois, we see that the non-Hispanic white and non-Hispanic Black males are impacted greatly. At a lower level, the non-Hispanic white and non-Hispanic Black females are also impacted. And then looking at geography now, new oropharyngeal cancers are seen at higher rates in the small urban and rural areas of our state, although cancer rates, the OPCC cancer rates is concerning in all geographies across the state, especially again, as mentioned, in the males. So just a quick review about oral HPV infection. So HPV consists of more than 100 types of variants, with infections becoming more common with increasing age. Now, majority, almost 100%, about 99 or 98% of the infections are cleared, but some remain, and that is a cause for concern in this webinar today. So HPV is a double-stranded DNA virus that infects squamous cell epithelium, which lines the entire oral cavity and the oral pharynx. About 40 subvariants of this should be HPV, can be spread through intimate contact with a variety of physical areas, including genital areas, mouth, and throat. Oral papilloma is an exophytic papillary lesion with a cauliflower appearance. It's raised or flat, and I'll show you some pictures of it that we see clinically. They can be solitary or multiple, may reoccur, and are not thought to cause cancer. The treatment for these is either excisional, complete excisional, or cryotherapy, some laser ablation, some intralesional therapy, such as injection with interferon alpha, and immunotherapy. So in the clinical setting, we will see papilloma growths like this, usually in the anterior portion of the mouth, although here there's one incident near the uvula. And again, the treatment is usually a patient will complain that, this is bothersome. They create a habit around it and the papilloma continues to grow. And so the treatment is either cutting it out completely or freezing it, cryotherapy, or some other intralesional therapies. So these are pretty self-limiting and they do tend to reoccur. What is of concern is the oropharyngeal squamous cell carcinoma, which usually occurs at the back of the throat, base of the tongue, and or near the tonsil. So really posterior portion of the mouth. HPV causes 70% of the OPCCs that are found, and HPV 16 variant is the most common type detected in OPCCs. Other variants associated with the oropharyngeal carcinomas include HPV variant 35, 33, and 18. For the oral health team, really our role is in the prevention and decreasing the risk of infection. So definitely the vaccination or providing counseling and recommendation for HPV vaccination before an HPV infection could occur. Stop or decreasing alcohol or tobacco use. In general, that is a good health maintaining strategy. Regular visual screening, early diagnosis and treatment for any kind of suspicious lesion. And then advising other kind of risk limiting behaviors such as appropriate use of condoms and even dental dams, which is a flexible barrier that is in sheet form that can also be used in limiting exposure to viruses, including HPV. The presentation of an oropharyngeal squamous cell carcinoma is a solitary tumor or lesion in the posterior mouth region with or without lymphadenopathy. Patient may present with symptoms consistent with persistent soreness, feeling of a lesion in the back of the mouth, in the throat, or the base of the tongue, difficulty with swallowing, possibly even speaking. A biopsy is needed to determine the diagnosis. Treatment is usually includes surgical intervention or therapies, chemotherapy, chemoradiation, immunotherapy, or some combination of all of the above. Prognosis in general is better for HPV positive oropharyngeal carcinomas compared with negative oral cancers. There are some clinical pictures of some presentations. So here's in the tonsillar area right here, and then here is a lesion at the base of the tongue, and then here it's in the posterior pharyngeal area. So So there are a lot of resources for oral health providers in talking with patients and parents around HPV vaccination and, of course, cancer prevention. So the National HPV Vaccination Roundtable has a terrific resource here, and I've provided links to these right in the slide set. So hopefully you can just click on it and go to this resource. It was developed with consultation with one of our dentists in our own state, Dr. Sharon Perlman. She's a really strong advocate for HPV vaccination. So go to that resource for much more detail. The other thing I wanted to also share is that oral health providers may see children and young adults and should take each opportunity to counsel them on overall health and prevention. And this slide shows the recommended schedule of doses based on the age of HPV vaccination initiation. It could be a little bit confusing when to counsel around 2 doses or 3 doses. And this is a quick little diagram that can help get this information across with parents and older adolescents so that they understand the difference between the 2-dose or the 3-dose regimen. And this is also another really good resource put together by CDC. Healthcare providers have multiple opportunities to talk directly with patients, especially young adults, around HPV vaccinations. And this resource is actually a plain language resource that can be helpful in your communication. And I encourage you to look at this and practice these scenarios in a question and answer format with other clinic staff so that you can make this a potential interaction with parents go easier, smoother, and provide a more understandable and strong recommendation about HPV vaccination. So this is a really good resource, a quick fact sheet that you could, again, as I said, practice so that when you do encounter an interaction where you could recommend a vaccination, you're much ready to do that, and that interaction goes smoothly with a strong recommendation. And then just quickly, we know that it's safe and effective. That's a message that we want to get across. The FDA has approved the HPV vaccination to be given to people up to the age 45 if that person's never been vaccinated. And then many people diagnosed with HPV negative oropharyngeal cancer cancers maybe as young as many people diagnosed with HPV positive oropharyngeal cancers, maybe as young as 35 to 40 years of age. So we really do want to get this information out to all age groups, not just the young children or not just the young adolescent, but even the older or young adult persons. The oral health community had a really strong impact during COVID. More than 1,000 Illinois oral health providers were engaged in COVID vaccination efforts. And, I really think that those experiences and having vaccination conversations in that dental setting can translate to gains in HPV vaccination as well. So, we're used to talking about health promotion and prevention messaging. We've talked about that around fluoridated water, good eating, and beverage behaviors. And now we need to expand that to include HPV vaccinations, herpes zoster vaccinations, especially for people over age 50. So, having a comprehensive an overarching health promotion and prevention messaging should also include HPV vaccination. So it's important in maintaining and decreasing illnesses, and we know that HPV vaccine has that impact as well. And our role as oral health providers is to increase self-action around protective behaviors. So kind of a quick review specific to oral health providers and oral health teams. Know your unique role. We could use the Illinois 9th grade dental examination that's bringing in children to get their required dental examination to talk with teens and parents about vaccine preventable illnesses. And we can make a strong recommendation to get their influenza vaccine, the HPV vaccine, their meningococcal vaccine. So, know our role. Know that a lot of 9th graders will have a dental visit possibly more often than a primary care visit. And so make a strong recommendation. So another thing is to review and document the health and vaccination history. We may not have that as part of our routine health history questionnaire, so make sure that you have that as you've included these vaccination items in your health history. Practice prevention and promotion, and importantly, anticipatory guidance that's meaningful for young adults. They're concerned about piercing and vaping and also cancer prevention, especially in the era of COVID. I'd heard a lot of teens wanting vaccination well before their parents or caregivers were ready to make that action or make that decision. So, talk to your teens around anticipatory guidance that's meaningful for them. Empower patients with reliable information. So that's another thing that our oral health providers and oral health team members can do. Refer to vetted vaccination sites. So doing what we call a warm handoff. So knowing and being ready to know who are the referral sources in your communities. And be ready to offer them that warm referral where that referral site is going to be able to take care of them, going to be able to provide the vaccine and associated support to get that care. And then importantly, engage your entire team. Practice with those Q&A, question and answer, so that the whole team can provide a consistent message around the importance of HPV vaccination and cancer prevention through that adopting of the vaccine. So a lot of the materials are available online. IDPH has had a couple of really good publications that you could read about HPV-associated cancers, specifically in Illinois populations. So that's also on the IDPH website, as well as these other CDC and oralcancer.org and the National Cancer Institutes also have some really terrific resources that you as an oral health provider or team member can use and adopt into your practice settings. So in summary, I just wanted to say that, clinician recommendations, as we've heard in previous webinars, remains the #1 reason that parents decide to vaccinate around HPV. Oral health providers should ask specifically questions about vaccination status, as I said, around influenza, HPV, of course, and meningococcal, and then herpes zoster for adults over the age 50. And add that to your health history form or your electronic health record. Measuring data in your practice is also a critical and potentially an impactful way to increase the number of vaccinated adults in your practice. So, for example, what is the percentage of vaccine eligible patients in my practice who report vaccination? And compare your vaccination rate of your patients, compare that to our county data or even the state data. So measuring data is gonna translate to improvements. Invite the whole team in the vaccination effort, and then know where your vaccinations are available in your community. So those are all things that oral health providers and oral health clinicians can implement in their practice to increase the numbers of people that are vaccinated with HPV. So I'm going to stop there and stop sharing, and those are my comments. Thank you.
Yeah, thank you very much, Dr. Cunningham. I don't think we usually focus on the dental health role in HPV, so I'm very glad that you were able to talk about it today. So I will remind the audience, if you have any question, please paste it into the chat, and then we will ask the panelists at the end of the presentation. So up next is Dr. Suzanne White, who is the Regional Medical Director for MEC. And I'm sure you've seen her before because I don't remember how many times she's presented to us. If you attended any of these groups, I'm sure you might have seen her before. So Dr. White, you can take it away.
Thank you, Eric, and Dr. Van Kennigan. That was an awesome presentation, reminding us really about the critical role that oral health providers have had during the pandemic, and continue to have, and will help close those gaps that we have to really address oral cancer and oropharyngeal cancer. So thank you. Just to build on those, you covered so much, and that was awesome. To build a little bit on that in terms of, what do we have in terms of evidence-based strategies to really build confidence in vaccines? Because even if we can get individuals in for their oral health visit and we have vaccines available, one of the most frustrating things is that we have an individual who does not want to be vaccinated for some particular reason. So perhaps they have a lack of confidence in vaccines, or perhaps they're just, they have questions, they want or need more information, and or perhaps they're ambivalent. They just don't think that this is a big issue for them. So what things do we think about in these situations? So that first, this is a lot of information on one slide, but that first situation is really about attitudes, and how do we move somebody from a state of vaccine hesitancy, a lack of confidence, to greater confidence in vaccination. What can providers do? What are the evidence-based strategies? What things work? And one is to develop a social media presence. So certainly we're at a stage now, we're at a time when that's where information is gained, and that's where we need to be able to create that same level of presence that we see others have that are putting out misinformation or even disinformation about vaccines. So it's important that, you know, we really use social media to the extent possible, and we can reach people early on, and this is key. So being able to get to people before they have formed strong opinions against vaccines is super important. We have a greater ability to build trust and to build confidence if we can get to them early. So super helpful. Use trusted messengers. So, you know, find those individuals like Dr. Ben Canigan, who's right there in Illinois. Those individuals like you, trusted members of the community that can speak openly, can talk about concerns, risks, and, you know, really keep pushing.
Did we lose Suzanne?
Yeah.
Suzanne, we lost your audio.
See if I can.
It looks like Suzanne lost her connection.
Yeah.
So we can go out of order. So Eric,
Yeah.
if you would like to go ahead and go next, and then we can pick back up with Suzanne when she reconnects.
Yes, that'll be fine. So I'm going to go next, and we will work with Suzanne when she comes in. And so today I'm going to talk about HPV vaccine hesitancy, and also I will talk a little bit about what an HPV vaccination champion is and what they do and how to select one in case you wanted to create one. So I have no disclosures. And for the first few slides, I will just go through them very quickly, simply because we've been talking about these a lot, but it's
I
almost.
apologize, Eric. I think my internet must have dropped us here. I
Dropped?
don't know at what point I cut out.
Okay.
Sorry about that.
You want to continue?
If possible, I will finish quickly. Like I said,
Okay.
it must have dropped for some reason.
So I think you were
yeah.
probably on the last
Yes.
box.
Yes. Hopefully you can see my slides again.
Yes.
Oh, really? Again, where I picked up, and sorry for the interruption, was really around understanding our communities so that we can really target messaging around the identity of our communities with those narratives. This, I think, Dr. Van Canigan covered very well, which is, you know, that culture of vaccination within a practice, how important that is to engage everybody from that person who checks you in to the person who checks you out, that everybody be focused on consistent messaging that's evidence-based, and you know, really that recommendation that we take advantage of every visit to review vaccine records and to create that opportunity, you know, for vaccination. So this is an important concept. It sounds simple, But it does involve educating, individuals who are on the team. It involves, leveraging strategies. And as I know, Dr. Ajay, Eric will cover, having that champion is super important as well. I think it's important, as you've done in your division, Dr. Van Hennigan, developing those evidence-based materials and toolkits and those lists that you just presented around where credible information can be found is very important. And certainly within a practice, to be able to include things in other types of practices around standing orders, reminder systems, things that allow us to schedule follow-up visits to get vaccinations scheduled to complete the series, because series completion is actually a rather big issue. We can initiate vaccination in probably 20 to 30% more individuals than we can complete. And we find actually that one of the things that is emerging, there's now a body of evidence around this that helps us to be very, very successful in completing vaccination, is that strong recommendation at the point of vaccination for same-day vaccination. And secondly, starting early. So life gets in the way and people miss their follow-up visits, they miss their completion visits. And so being able to start as early as age 9 is associated with higher completion rates nationally when we look at that. Developing a curriculum like we are here, where we have longitudinal seminars to educate, to create awareness, is helpful. And then behavioral strategies, interventions that help to promote vaccine confidence. We won't have time to go into this today, but there's certainly a lot of information around what do you do when someone is hesitant in front of you? What type of conversation should you have? Communication is so important. How can we then develop our motivational interviewing techniques and strategies to really help move them toward vaccine confidence is really important. Take a look at these websites for credible organization references. Amazing information at these sites that will help up-to-date information and ideas about how to distribute educational materials. And again, just to summarize quickly, that culture of vaccination within the practice, within the setting and the organization is very, very important. Making sure that we have evidence-based materials, that we leverage digital materials and social media, that we use trusted messages, that we target messages to our communities around their identity and their personal challenges, and then again keep that list of credible organizations on hand as well, so that you can continuously update your staff and your providers. Thank you so much, and I'll turn it over to Dr. Ajay.
Thank you, Suzanne. That was quick. So I will also try to be quick so we get time for question and answers. And if time permits, we'll come back and talk a little bit more, especially about those behavioral changes for vaccine hesitancy, since that's exactly what I'm going to be talking about. So I'm going to continue. Let me just start to be safe. So I had no disclosures, and I will talk about HPV vaccine hesitancy and the role of HPV champions, vaccination champions.
Eric,
So we'll start.
we can't see your slides.
Oh, okay. Let's see. Okay. I'm sure you can see it now.
Yes.
Okay. Yeah, it was on my other screen as usual. So I'm going to talk about HPV vaccine hesitancy first. And I won't talk about these slides. I just put them in here just for those that will be listening to the talk online, since if I start at HPV vaccine hesitancy, it will be kind of a little bit weird. So we know HPV causes all these diseases and cancers. And this is something we don't talk about a lot, but a few studies have shown how HPV also actually cause second primary cancers, which is a, a, a cancer survivor who develops another brand new cancer. And the new cancer is very different. It's not recurring. So for example, someone develops a breast cancer and then they develop lung cancer. So it's not the breast cancer spreading to the lungs. It's a brand new lung cancer. And as you will imagine, if you have HPV infection, if you get one HPV associated cancer, there's a very high risk of developing another HPV associated cancer. And the risk is about 73% higher. So I just wanted to point this out. And then the story is there is a vaccine to prevent all these HPV infections, which leads to all these diseases. And however, vaccination rates are very low. So you've seen these numbers for 3 consecutive times. So I won't spend a lot of time on it. But basically, initiation is about 77%, completion is about 62%. So as Suzanne mentioned, completion is still very low compared to initiation. So this is where the vaccine hesitancy comes in. So a lot of studies have looked at what are the reasons why HPV vaccination rates are low, or they lag behind other child and adolescent vaccines. And lack of provider recommendation is obviously the number one reason, but there's one of the second, third ones most people talk about is vaccine hesitancy. And it turns out vaccine hesitancy is actually one of the top 10 health threats that WHO identified in 2019. And in the United States, 1 in 3 families are HPV vaccine hesitant, which is very, very, very high. So I did look at a few studies that have looked at all these reasons. So this particular study did use the National Immunization data set. And so I believe 2 weeks ago, Dr. Vu presented this same information. I think that was hint, but maybe this one, looking at broken it down by race, ethnicity. And this is looking at among those that are unvaccinated. So they asked parents whose children were not vaccinated, how likely they were to vaccinate their children in the next 12 months. And so, and if they said no, then they asked them why, what is the reason why you don't want to vaccinate your child? And so there are a lot of reasons. There are about, I believe, like 28 different reasons parents gave, but the top 5 makes up over 70% of all the reasons. So this study focused on only the top 5. And so this study looked at it from 2010 to 2020. And this is just to look at the trend in those reasons. And so as you can see, most of it started high a little bit, but they've been going down at least. So that is a good news. So for example, if you look at the number of patients who endorse not necessary as the reason for not vaccinating their child, it went up a little bit, and then since 2015 it's been going down. So, and almost all of them are going down. except the proportion of parents who are citing safety or side effect concerns as the reason for not vaccinating their children. And this is very concerning since the vaccine has been approved since 2006 for adolescent girls and 2009 for boys. So if in 2019, people are still citing safety concerns, this is very concerning. It means we are not doing a good job explaining either the efficacy or side effects or the safety of the HPV vaccine. And then, so going forward, I decided to just break them down by socio-demographic factors of either the adolescent child or the mothers. And so when you break them down by the child, so the reasons for children seems like it's been stable, nothing is changing. So it went down from 2010 to about 2012. And since then, almost every reason has remained stable. The good news is parents who have children age 13 has been decreasing slightly. So this is a good sign. So probably the recommendation that we should start recommending the vaccine earlier, even at 9, seems to be a good one. If you look at gender, no big changes. It decreased a little bit. I don't know what happened in 2012, but it seems like in 2012 is where everything changed. And so it went down, and then female is a little bit slight. Thank God, adolescent males are going down slightly. And then if we look at this by race, ethnicity, it's relatively stable for non-Hispanic white, non-Hispanic black, non-Hispanic other. However, since 2013, it seems there's a slight increase for non-Hispanics, or not, sorry, Hispanic adolescents. So we need to find out why Hispanic adolescents or mothers of Hispanic children are becoming more hesitant. This is looking at it by poverty status. Nothing has changed. This is probably the one that looks the most stable, even though it should be noted that there's a higher proportion of, or the proportion of parents citing the proportion of parents with above the poverty, the vaccine hesitancy is much higher compared to those below poverty level. And this is also very interesting, but it's a little bit consistent with the literature. And then these are the mother's characteristics. So this is looking at mother's marital status. So if the mothers were married, then their vaccine status, vaccination hesitancy is higher than if they are not married, which is also very concerning since we want them, they are the ones, hopefully with children, that should be less hesitant. But it's been stable, so that's the only good news. The bad news is it's still very, very high. And then this is the last one that looked at these changes by the mother's education. So here too, it's always been very stable since 2012. And then it's very low for parents with or mothers with less than high school. So it seems like either providers are recommending the vaccine more or talking about it more for people from lower socioeconomic status than higher socioeconomic status, or there is something else going on, especially if you combine this with the ready status. But we also know it makes sense a little bit because we also know that in general, people of higher socioeconomic status tends to be more vaccine hesitant than those with lower socioeconomic status. So I will shift a little bit and talk about HPV vaccination champion. So Dr. White mentioned this briefly. This has been one of the things that have been suggested as one of the strategies to improve HPV vaccination. What is an HPV vaccine champion? Usually this is a person that advocates for changes and everything to improve HPV vaccination. And this role is usually filled out by a provider at a clinical or healthcare organization, but technically it can be anybody. It can be a parent who cares about their child's vaccination. It could be nurses, it could be physician assistant, and then it could be dental professionals. So this is very important, especially as you heard Dr. Cunningham talked about. And what does a champion does? So usually they just help structure and drive change in an organization. That is basically their main thing. And they serve as advocates for immunization in general. The benefit of having one, just helping implement changes, and then also, especially if they are in dental health professional, then they are going to help connect people, their patients to vaccination sites. And in case you want to identify what to look for, so someone who is really interested in HPV, someone who cares about improving HPV vaccination will be a good one. They should usually have a leadership role because so that people will listen to them. So if you work in some, say a healthcare organization, it could be like a department chair. So for example, if Dr. Cunningham is a champion, I'm sure if she says things, people who report to her will think, oh, she thinks it's important, so maybe it's important, something like that. And then the last one is they should have time. So it should not be someone who is so busy, because even if they care and they don't have the time to dedicate to it, it's not going to work because they're going to have to meet, try to convince people for you. And so that is it. And the last one I added was that you may need more than one. So I'm going to stop here. And then I think we have about 10 minutes for questions and answers. So I'm glad I went through quickly. And Linda, is there any questions I missed since I couldn't see the chat as I was presenting?
No, I have not seen any questions. But if anyone has any questions for, any one of our three speakers, feel free to enter it in the chat. Or if you want to raise your hand and I can take you off mute.
So I will start by asking maybe a couple as other people think about questions. So Dr. White, you want to talk a little bit about the behaviors to change or the social media part, the presence on social media, because most of the things driving vaccine hesitancy, especially in this age, is social media or maybe all online things. So a lot of negative things online about vaccine causing this, vaccine causing this. So how can we interact this, since we know that negative things tends to be more popular than the positive things?
Yeah, I mean, this is an important thing that I think we've learned over the past several years is that the number of hits on social media sites that are forwarding, misinformation or disinformation far outweighs the number of hits at sites that have credible information. And so I think a lot of us have been so engaged in, the aspects of education, traditional ways of educating and vaccinating and cares of patients, and the impact of the pandemic, that we haven't really thought out a social media strategy to be able to push out evidence-based messages. Some of the good examples I've seen have come from state health departments, for example, where they have crafted templates that can be used by provider practices to send out information and push that information out to their patient panels, for example. The American Academy of Pediatrics has some wonderful messaging in their toolkit. You can go to the Colorado toolkit, for example, and that particular health department has taken those AAP messages and, really, I think, done a really nice job of creating customizable templates where people can just insert their own practice name, phone number, and you can pick the appropriate, photographs that are kind of eye-catching and, have important messages and recalls, for example, to get patients and parents to come in. So, really beefing up, I think the onus is on us to really beef up our strategies to match or even exceed those that are being used by those who are really, the sources of misinformation.
Yeah, I agree with that. Dr. Cunningham, you want to add anything?
No, Dr. White, just terrific. I mean, I know that having information coming from the state health department is pretty impactful and helpful for individual practices so that they don't have to create information on their own. And really just, yeah. And again, it provides an avenue for consistent messaging.
Yeah, I agree with. I'm not going to this doctor, or I'm not going to see, because they talk to me about vaccine hesitancy. If it's consistent message, then they know it's not coming from you. You're just promoting it. So I like that one. I didn't see any more question. So I will ask one more, especially to Dr. Cunningham. So if dentists could give the vaccines rather than just recommending it or talking about it, do you think that would make any difference? I know there's been a push about trying to get dentists to actually be able to give the vaccines rather than just recommend it or talk about it.
Yeah, I mean, any time that a healthcare setting can meet that person's healthcare need right there is a good thing, right? The challenge in a dental practice is that a lot of times they're standalone, not just physically located, but they have a separate electronic health record. They have a separate, maybe not even inputting into the Illinois like vaccination database, iCare. So we're not sure exactly, like, have they received the first dose and are they ready for the second dose? Or, that kind of like isolation of the dental practice poses a lot of barriers to actually, be a vaccination site. In addition, there's a lot of requirements around vaccine, making sure that it's at standard temperatures, and all the quality assurance piece of that might not enable a dental practice to to efficiently provide vaccination. And that's why I think it's really important for a practice to understand where is my local vaccination site. Can I make an individual relationship with them so that I can, when I send my patient over there, that they won't get a runaround, they'll get the care that I'm recommending. Maybe I can even help make the appointment. I mean, something like that. I think those are all things that a practice could consider as like more amenable to increasing vaccination rate, because I think the challenge of actually providing vaccine in the dental setting, especially for HPV, those barriers are pretty high. In Illinois, at least. I think there might be one state that might be doing where dentists are providing HPV vaccine, but it's not widespread at all. Mhm.
Yes. See, I saw a question. Oh my goodness, you might have answered this even though I.
Okay.
Dr. Wu says, can you discuss some of your experience with implementing best practices around HPV vaccination in dental care practices and other practices in general? And what are the facilitators or barriers in this?
Yeah, I mean, I think that one facilitator is that about 65% of the population visits their dentist at least once per year. So, they may be visiting the dental office more regularly than a primary care or other type of healthcare setting. So I think that's a facilitator. And if you're going to have an incremental conversation with someone, maybe the first time it's an introduction, second time it's additional information to get to a point where that person, that parent is willing to make a change, saying, yes, I'll do this. And then you can connect them to that vaccine source. So I think, dental practices can be a strong facilitator. In addition, we're looking in the mouth. That's our area, and we're talking about OPCC, and that is our area of work. And so, it makes us powerful advocator and potentially a powerful recommender for HPV vaccination.
Yeah, I agree. I think, even if they could hand out something, even if they are not comfortable talking, but they had information, pamphlets, in addition to things they give it to you, they stick it in your bag after cleaning and you take it home. I'm sure some people at least will read it. So that, I don't know how much difference it will make, but at least it would introduce the topic in the home. So we have 2 minutes. You have anything to add, Dr. White?
No, I just think that's such a, as you pointed out, Dr. Van Kenigan, that the power of the recommendation. We look at all the evidence-based strategies that are out there, and there are a lot. We've only touched on those today, really. But that recommendation coming from the dentist, or the on the other side, the physician or the nurse or the provider, who's the person that they trust, carries the best evidence of anything else. It's a tenfold increase in vaccination uptake based on that recommendation. So it's that strong, confident, same day recommendation to get the vaccine. It's important. If you have to, spend a little bit more time discussing why it's important, certainly. And always don't be afraid to use storytelling. As an oral health provider, you've seen oral cancer. You've seen what it does to people's lives. And, don't be afraid to say that, that, you're vaccinated, you vaccinated your children. Those are very, very powerful things, and they're all things that we've studied and we know work.
Yeah, and Eric, if I may, I want to add that, the rest of the oral health team is also important, because a lot of communication happens between a dental hygienist and the patient. And increasingly, community health workers and someone getting oral health services. So we have to utilize, as you said, and as Dr. White said, use the entire team, because somebody is going to be able to communicate and meet the information needs of that parent or that adolescent. And the more people, more diverse people that we have talking, the better, I think.
All right, so thank everyone. As you can see, I never asked myself any question because I didn't see any question for me, and I was in charge. So the benefit, it's 2 o'clock. So I want to thank Dr. White and Dr. Cunningham for joining us today and sharing the experiences with us. And I want to thank Elise and Linda for helping us organize these. There's going to be 1 minute or so survey that will be sent to you after you sign this off. Please complete this for us so that we will do a better job going forward. And thank everyone for joining us today. And we hope you enjoyed this LEARN lessons, HPV LEARN lessons, and there will be more on other subjects in the near future. So thank you very much.
Thank you.
Bye.
Bye now.